Good morning, Director Ma'am, and all respected faculty members. Today I've got this opportunity to present clinical grand rounds from my department of nuclear medicine. So we'll be discussing about lutetium EDTMP therapy, which will be a case-based discussion of the efficacy and safety in patients with multiple skeletal metastasis and bony pain. So first we'll be covering two cases for the same and then coming to the discussion summary and a clinical audit over some of the patients which we have done in our department. So coming to the first case, Mr. X, who is a 68-year-old male, a resident of Rishikesh, presented to the department with complaints of dribbling of urine and difficulty in passing urine since 2 years. The patient was referred for an ultrasound abdomen and pelvis, which suggested grade 2 prostatomegaly. An MRI was suggestive of Pirates 5 lesion in the prostate, and a truss guided biopsy was done, which. Ma'am, Pirates is prostate imaging and radiological diagnosing system, and USG is ultrasound, and truss is transrectal ultrasound guided biopsy, which was suggestive of prostatic adenocarcinoma, Gleason score of 10, 5 plus 5, and the patient was diagnosed as a case of adenocarcinoma prostate. So patient had underwent a prostatectomy in April 2023, and patient was apparently well for the next 3 months when he started experiencing a recurrence of symptoms. He also experienced bony pain at multiple sites throughout the body, including bilateral shoulders, cervical neck region and low back region, along with bilateral proximal thigh pain since 8 months. Pain was insidious in onset, gradually progressive, which started as moderate intensity and progressed to a severe intensity in a span of 2 months. Then the patient was started on tab enzalutamide. The primary treatment was being undertaken in the Department of Medical Oncology, and the patient was started on enzalutamide followed by abiraterone in November 2023, and still no disease control was achieved. Currently, the patient, when he presented to our department, the patient was on palliative therapy, injection leuprolide, zoledronic acid 5 mg monthly, and the patient was also taking tramadol 50 mg and buprenorphine 10 mg LA with pregabalin for complaints of pain after the patient's symptoms weren't controlled with NSAIDs. So even after exhausting all trials of analgesics, including opioids and pregabalin, no significant pain relief was achieved and quality of life was being severely affected. So the patient was referred from medical oncology and planned for lutetium bone pain palliation therapy in our department in March 2024. So a clinical examination was undertaken for the patient in our department. The patient was moderately built with a weight of 68 kgs, and ECOG status was 1. Karnofsky performance score was 60, which means the patient was ambulatory but had difficulty in doing daily activities. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema was there. The vitals for the patient were pulse rate was 80 per minute, BP was measured in sitting position in the right arm, which was 130 by 78 mm of Hg. Respiratory rate was 14 per minute. SpO2 was 100% on room air and temperature was 99 degrees Fahrenheit. Local sites of pain were also thoroughly examined for any swelling. Any neurological deficits or signs of nerve compression involving sites of pain were ruled out, because all these are contraindications for lutetium therapy. Any recent history of pathological fractures were also ruled out, and any history of recent chemotherapy or radiotherapy within 4 weeks was also carefully ruled out. In per abdominal examination, no organomegaly or free fluid was there. In cardiovascular system, S1 and S2 were hurt and no murmur was there. In pulmonary system examination, respiratory system examination, bilateral air entry was present and no Krebs were found. In CNS examination, The GCS status was E4, V5, M6, and no focal neurological deficits were there. The post-prostatectomy, for the complaints of multiple bony sites, multiple pain at bones, the patient underwent a CE-MRI dorsal lumbar spine with whole spine screening, and it revealed heterogeneously enhancing altered signal intensities in all visualized vertebral bodies and their posterior elements, likely metastasis. So, for undergoing a lutetium bone pain palliation therapy, it is mandatory to do a 99M technetium MDP whole body scintigraphy, and it was also suggestive of multiple osteoblastic skeletal metastasis. So this is the image of 99M technetium MDP whole body bone scintigraphy, which we had done in our department. It was suggestive of multiple osteoblastic skeletal metastasis involving the sternum.
Pointer.
Yes, ma'am.
Show it on the image.
So, involving the sternum, multiple ribs bilaterally, then there is bilateral scapula, cervico-dorsal-lumbar vertebra, bilateral pelvic bones, proximal humeri and proximal femurs. And then there were benign arthritic changes involving bilateral knees, as well as the bilateral kidneys were faintly visualized. This was suggestive of multiple osteoblastic skeletal metastasis involving the skeleton. So then, before giving lutetium therapy, we have to get a baseline blood investigation. So the CBC was suggestive of hemoglobin within normal limits, which was 12 grams per DL. WBC counts were 3,890 and platelet counts were 1,34,000. Urea was 34 mg per DL and creatinine was 1.04. Serum PSA was highly raised. It was 3,650 nanograms per ml, and ALP was also raised because of the bony pathology. And pain score was evaluated using a brief pain inventory form. It was found to be 7.8 out of 10. So this is a brief pain inventory form. It consists of 10 questions, and the patient has to circle or tick the pain score, and 0 is no, like a negative score, and maximum score is 10. So finally the clinical diagnosis made was metastatic adenocarcinoma prostate with multiple bony metastasis and bone pain corresponding to the sites of skeletal metastasis. Status post prostatectomy in April 2023 and 4 cycles of chemotherapy in November 2023. And the patient is on palliative injection leuprolide, zoledronate, and tramadol, buprenorphine, and pregabalin for bone pain. So the patient received 1 cycle of 50 millicurie lutetium EDTMP therapy. The dose is approximately 1 millicurie per kg. So this was done on 4th April, and the patient was under supervision with regular vital monitoring every 15 minutes for 2 hours post-injection period. And the patient was discharged after 2 hours when the dose rate limits were within normal limit. So post-therapy, a 24-hour lutetium EDTMP biodistribution scan was done, and it showed good distribution of the tracer at known sites of metastasis in the present study. So this is again the post-therapy lutetium scan. It is showing corresponding findings to the bone scan which we had done previously. So again, the sternum, there is good tracer distribution in the sternum, bilateral multiple ribs, and the cervico-dorsal vertebra, bilateral scapula, proximal humerus, proximal femur, and bilateral pelvic bones. So this confirms that lutetium has gone to the sites of metastasis, and we'll be able to see the effect further in the follow-up. So in post-therapy, the first week follow-up, blood parameters are again done, and pain score was also calculated using the same form. Pain score now had reduced 2 scores from baseline, which is 6, and blood parameters were again within normal limits. Then during the second follow-up, which was the 3rd week follow-up, the pain score has reduced to 4, which was reduced 4 scores from the baseline, and again the blood parameters were within normal limits. Then in the 5th week, again pain score had reduced 5 scores from the baseline and blood parameters were within normal limits. And the last follow-up which we have done is the 7th week follow-up, and pain score has was same as the previous follow-up, which was reduced 5 scores from the baseline, and the blood parameters are again within normal limits. So this is a follow-up summary. So we can see the trend that within the first week, pain score has reduced by 1, but during the follow-up period, the pain score is again reducing. From the baseline, it has reduced about 5 scores, and blood parameters usually are expected to drop near the 4th week post-therapy. So there we also have found a slight drop, but again the parameters were usually within normal limits, and now all the parameters have returned to the near the baseline parameters, and the pain has significantly reduced. So coming to the second case, this is a case of Mrs. Y. She was a 48-year-old female, a resident of UP, and she presented with right breast lump since 2 years, which was the size of a pea when first noticed by the patient herself, and it increased in size to a tennis ball in a span of 4 months with no associated pain, pus or discharge or nipple inversion. The USG mammography was done, and it was suggestive of right breast Biret's 5 lesion, and CCT was suggestive of right breast lesion and sclerotic lesions involving multiple visualized vertebrae, which were likely metastasis. Then histopathology was done from the lesion, and it was suggestive of invasive ductal carcinoma in the right breast with Nottingham grade of 1, and immunohistochemistry was suggestive of ER/PR positive and HER2/neu negative pathology. So she was diagnosed as a case of invasive ductal carcinoma, right breast, with multiple bony metastasis, and the patient underwent 16 fractions of RT in Feb 2023, followed by 16 cycles of chemotherapy. Last was in October 2023. The patient was still experiencing bony metastasis, bony pain at multiple sites throughout the body, including head, bilateral shoulders, proximal arm, cervical neck region, and low back region, along with bilateral proximal thighs. Since 3 months, the pain was again insidious onset, gradually progressive. It started as mild intensity and progressed to severe intensity in a span of 3 months. The patient was given a trial of fulvestrant followed by docetaxel and gemcitabine with no disease control, and then the patient was shifted to palliative therapy with letrozole hormonal therapy and palbociclib palliative therapy, along with zolindronate 4 mg monthly and Ultracet, which is again tramadol opioid 40 mg BD plus SOS for complaints of pain with still no improvement of symptoms. So even after exhausting all anti-analgesics and opioids, no significant pain relief was achieved, and quality of life of the patient was again affected. So the patient was referred from medical oncology again for lutetium EDTMP palliation, pain palliation therapy in our OPD in April 2024. Now, again, the clinical examination, patient was moderately built and nourished. The ECOG score was 1 and Karnofsky performance scale was 70. No pallor, icterus, cyanosis, clubbing, lymphedema, lymphadenopathy or edema were found, and the vitals were 74 per minute. Blood pressure was 128 by 72 mm of mercury, and respiratory rate was 16 per minute. SpO2 was 100% on room air, and temperature was also normal. Coming to the local sites of pain were also thoroughly examined for any swelling. Any neurological deficits or signs of nerve compression were again ruled out. Any history of pathological fractures were also ruled out, and any recent history of chemotherapy or radiotherapy were ruled out. In per abdominal examination, no organomegaly or free fluid were found. In cardiovascular system examination, S1, S2 were heard and no murmurs were there. In respiratory examination, bilateral air entry was present and no Krebs were found. In CNS examination, GCS score was 15 by 15 and no focal neurological deficits were there. So patient had underwent an 18F FDG PET CT in March 2024, which showed multiple bony metastasis. Post RT gemcitabine zoledronic based chemotherapy, as well as the hormonal therapies letrozole, palbociclib, and zoledronate, and there was even interval increase in size and the metabolic activity of soft tissue lesions. Then again a baseline bone scan, which is compulsory, was done. It was also suggestive of multiple osteoblastic skeletal metastasis. So this is the image of this patient. It was showing multiple skeletal metastasis involving the skull, sternum, bilateral ribs, multiple bilateral ribs, then proximal humerus, and then bilateral scapulae, then bilateral pelvic bones, and then proximal femurs bilaterally. And bilateral kidneys were well visualized. So again, this patient was a case of multiple osteoblastic skeletal metastasis. Baseline blood investigations were done, which were again within normal limits, and pain score calculated from the brief pain inventory form was found to be 8.4 out of 10. So the final clinical diagnosis made was carcinoma right breast, status post 16 fractions of RT in Feb 2023 and 16 cycles of chemotherapy in October 2023 with multiple skeletal metastasis and bony pain corresponding to sites of metastasis. Currently, the patient is on zoledronic acid, palbociclib, and letrozole hormonal therapy. And for bone pain, she was taking Ultraset, which is tramadol 40 mg BD plus SOS. And so the patient received one cycle of 50 millicurie lutetium EDTMP therapy in April 2024 and was under supervision with regular vital charting every 15 minutes for 2 hours post injection period and was discharged after 2 hours with the dose rates within normal limits. So this was the 24-hour biodistribution scan after post injection. So again, it was suggestive of good tracer distribution to the corresponding to the bone scan findings, which is the skull, sternum, bilateral multiple ribs, humerus, multiple cervical, dorsal, lumbar, and sacral vertebrae, and the bilateral pelvic bones and bilateral proximal femurs. So again, follow-up pain score and blood parameters were evaluated. In this patient, within the first week, we have seen a reduce in 3 scores from the baseline, and pain reduction of 2 scores is usually considered significant from the baseline, and blood parameters were within normal limits. In the third week follow-up, the patient's pain had reduced to a score of 3, and which was 5 scores from the baseline, and blood parameters were again within normal limits. In the 5th week follow-up, again the pain score had remained same as the previous, and blood parameters were again within normal limits. And in the 7th week follow-up, which was follow-up 4, we are doing 2 weekly follow-ups for these patients. So pain score had reduced to 2 and blood parameters were again within normal limits. So this is a summary of the follow-ups. So pain score within the first week, second week, first week, third week, 5th week, and 7th week. So currently the pain has reduced 6 scores from the baseline, and in this patient again around the 4th week follow-up, we expect to have a reduction in the blood counts. So near the 5th week, this patient had somewhat neutropenia from her baseline and 9.8 hemoglobin, but it has come again to the normal baseline parameters. So coming to the discussion, skeletal metastases are common in many malignancies and remain a major cause of morbidity and mortality in 65 to 75% of patients with advanced breast and prostate cancer. Patients with disseminated skeletal metastases often experience severe refractory pain, which may impair the quality of life. So the goal of treatment in these patients is pain palliation. Uh, and the standard currently available treatment modalities are analgesics, bisphosphonates, chemotherapy, external beam radiotherapy, immunotherapy, surgery, and hormonal treatments. Often, the management of pain due to widespread skeletal metastasis is not only a challenge to the treating oncologist but also adds to the financial burden of the family of such patients. So, bone pain palliation is an easy to administer radionuclides offer advantage including simultaneous treatment of multiple metastatic foci, repeatability, and also the combination with other treatments. Not only does radionuclide therapy alleviate the pain, but it also reduces and defers the incidence of skeletal related events. These agents bind to the hydroxyapatite in bones and delivers ionizing radiation to areas with increased osteoblastic activity. It is of substantial importance to deliver the utmost radiation to metastatic foci while sparing the non-affected tissues. So, lutetium is considered an excellent radionuclide for bone pain palliation owing to its favorable physical characteristics, including a half life of 6.7 days, the beta energy maximum of 497 kilo electron volts, and a gamma energy of 113 and 208 kilo electron volts, which is for the for the scanning we use the gamma energy, and these all characteristics are suitable for treatment as well as scintigraphic localization of bone metastatic sites. And an indigenous large scale production of lutetium is possible in India in adequate specific activities using moderate flux reactors at an affordable cost. So, coming to the mechanism of pain palliation, how lutetium is causing pain palliation in these patients. After injection, these isotope carrier complexes attach to the hydroxyapatite in mineralized bone, particularly in areas of high bone turnover rates at metastatic sites. And once localized, these radionuclides decay and emit alpha and beta particles or gamma rays and a combination of these. And the beta emissions in this case cause cell damage directly through the DNA damage and cell apoptosis in inflammatory cells. This involves a reduction in pain mediators like histamine, prostaglandin E, interleukins, leukotrienes, and substance P produced by the tumor and inflammatory cells, and also radiation induced mechanical factors such as a reduction in the periosteal swelling. There are some important contraindications to lutetium therapy, which includes leukocyte and thrombocyte counts below 4,000 and 1 lakh respectively. Patients with impaired renal function, creatinine more than 1.5 are excluded. Patients with pain caused by pathological fracture, infiltration of nerve or peripheral nerves are also should be excluded. Patients with pregnancy and breastfeeding are contraindicated. Patients with acute compression fractures or patients who have received chemotherapy, immunotherapy or EBRT within last 4 weeks. Any previous systemic therapy with radioactive materials in our department as well, including strontium, samarium and rhenium. And some adverse effects associated with lutetium therapy include anemia, leukocytopenia and thrombocytopenia, and fever, which may again be associated with leukopenia and renal toxicity. These all are mostly experienced. Leukopenia most commonly is the one adverse effect which is experienced, and it is found near the 4th week post injection. So, evidence for the use of lutetium therapy in 2005, Nishio et al. Had suggested that radiopharmaceuticals already in use are effective, but there is a need for radiopharmaceuticals with better nuclear decay characteristics and better biological behavior with less toxicity like lutetium to make them affordable to ensure greater accessibility of for the patients. Yuan et al. In 2013 have reported a response rate of 77 to 100% in studies using lutetium EDTMP for treatment of bone metastatic pain. Chakravarti et al. In 2021 have reported that lutetium EDTMP not only has excellent pharmacokinetic and dosimetric characteristics, but it is also safe and effective. There was no difference in toxicity or efficacy between patients receiving a lower dose or high doses of lutetium EDTMP therapy. So this is a clinical audit of the overall the 5 patients which we have currently done in our department. The first case was, which we have discussed already, the prostate cancer with multiple skeletal metastasis. Uh, the clinical response has been found to be a significant pain relief. Uh, and status at present, fourth follow-up, which is the 7th week follow-up, has been completed, and pain reduction of 5 scores we have found from the baseline. In the second patient, she was a case of left breast carcinoma with multiple skeletal metastasis. Again, a significant pain relief of reduction of 4 scores from baseline has been found. CA right breast was the third case. Again, she has reported a pain reduction of 6 scores from baseline. CA prostate was the fourth case again. We have administered in May 2024, and the third follow-up, which is the 5th week follow-up, has been completed currently, and the patient has experienced a 3-score reduction from the baseline. The 5th case, which we have recently administered in June 2024, is a case of CA right breast, and the first follow-up has been completed, but the patient has only experienced a reduction of 1 score from baseline, which is clinically not significant. We'll wait for the second follow-up for this patient. So usually people think that nuclear medicine is a diagnostic branch, but theragnostic agents are also there in our department, which is the therapy agents. Firstly, iodine-131 radioactive iodine, which is used for treatment of hyperthyroidism, including Graves and toxic multinodular goiter, and in cases of thyroid carcinoma. The mechanism of localization of radioactive iodine is through sodium iodide importer in the thyroid follicular cells. Iodine 131 MIVG is an agent which is used in cases of neuroendocrine tumors such as pheochromocytoma, paraganglioma, neuroblastoma, and carcinoid tumors. It is localized through norepinephrine transporters in these tumors. Lutetium-177 and actinium-225 PSMA. These agents are used for prostate cancer in metastatic castration-resistant prostate carcinomas. Post trial of docetaxel or cabazitaxel chemotherapy, and it is localized through the PSMA ligand in prostate cancer cells. PRRT, which is using lutetium-177 or yttrium-90 dotatate or dotatalk, again are used for neuroendocrine tumors, and these are localized through the SSTR receptors. Skin patch radionuclide therapy is using yttrium-90, holmium-166, and lutetium-177, phosphorus-32, and rhenium-188 are used in cases of keloid or skin carcinomas, and it is the mechanism is through direct radionuclide irradiation. TARE using yttrium-90 theraspheres and holmium-166 microspheres is used in cases of unresectable hepatocellular carcinomas or small tumors located near large vessel where surgery is contraindicated. It usually acts through blocking the microcirculation of the tumor vasculature, resulting in ablation of the tumor cells. Then metastatic bone pain palliation, as we have discussed, using lutetium EDTMP. Other agents are also available, including samarium and samarium EDTMP and 223 radium chloride. These are used in cases of refractory bone pain due to osteoblastic metastasis from prostate, breast, or other malignancies. These are absorbed into the skeletal metastatic sites, and through alpha or beta emission, these cause the death of inflammatory cells and reduction of cytokines and growth factors, causing the bone pain. Cancer patients with multiple skeletal metastasis and bone pain are amenable for lutetium EDTMP therapy. After a baseline bone scan, complete blood parameter check, and excluding pathological fractures or neurological deficits. And lutetium EDTMP is a safe, effective, and easily accessible radiopharmaceutical with high response rates in patients with multiple bone metastasis corresponding to sites of pain. So this is a newer therapy which we are doing in our department, and patients with multiple skeletal metastasis and bony pain corresponding to these sites can be given this therapy if they are refractory pain after opioid trial, if they are still having.
Is there anything else? That's
No.
over. No?
Yes.
So, session, any queries we would like to invite you.
Good morning, everyone. Earlier we were taught this was ages ago, that only radiotherapy was the one which was used for bony metastasis and alleviating the pain. But then I think nuclear medicine has come a long way in alleviating pain. Two things. Do they carry radiation with them? Now that we have given them injections of this medicine and you are sending them home after 2 hours, and you are following them for about 6 weeks subsequently, do they carry radiation with them? Do they need to be isolated? Number one. Number two, how many times can we give this kind of therapy for them if it is not getting treated? Number three, is it applicable to everything or only specifically to prostate and breast that you have been talking about? And where does that leave radiotherapy now in the treatment of radiation therapy now in the treatment of bony metastasis?
Actually, because while we are discharging the patient, we are giving them all radiation safety precautions are being explained to the patient. The patient is carrying radiation at that time when we are discharging, but the patient, if adequate hydration is maintained, the patient will be relieved of maximum of the radiation by around 1 week, which is the half-life of lutetium is around 6.7 days. So after that, the patient is usually rendered with the minimum radiation, which will slowly leave the body if adequate hydration is maintained. All radiation safety precautions have to be followed for 1 week. The patient is to be isolated in a separate room, and the fomites and utensils of the patient have to be isolated for 1 week. The patient has to maintain a 2 feet distance from pregnant females or children for 1 week. And then the second question was
Whether it is applicable to all cancers.
Yes, ma'am. Actually, the mechanism of localization for this patient is through it binds to the areas of increased osteoblastic activity. So, any cancers which we are having osteoblastic metastasis in the bone scan, which we are doing initially, we can give this therapy to these patients.
I'd like to add a few more.
Breast and prostate are osteoblastic.
So, ma'am, regarding the radiation precautions, ERB has set limits for various radioisotopes, so lutetium, iodine, etc. Whenever we give a particular amount of dose is given, so there are limits that this much dose can be given on OPD basis, and more than that has to be given on indoor basis. So this lutetium comes under the outdoor basis therapy, where the radiation exposure is there within the patient, but whatever is being coming out from the patient is safe enough for the patient to go into the community. So every patient will have some radiation, but it is not dangerous or it is not risky for the general population. So ERB has permitted on OPD basis. So this is the first thing. Second is these patients or patients with multiple bony metastasis respond with single site or localized radiation radiotherapy. Patients with nerve compression, spinal impending compression or neurological deficits, radiotherapy, and multiple sites would be covered by this thing. Second, the thing is about whether all cancers can be treated. Yes, all patients with multiple bony mets can be treated, but we expect that patients with a median survival of at least 3 months are preferred for this, like CA gallbladder and malignancies which do not have a very high median survival rate are not preferred for this. So because they will not respond well before that, there will be some other complications. So we usually prefer patients who have long life, even with metastatic disease, which is in these two malignancies only. But they can be given with other malignancies as well, if they fit into that. And it can be repeated, minimum of after a few months, after 2 to 3 months. Usually you keep on seeing the response. What we are seeing is, I don't know, it's a very initial phase. We are seeing response very early, but usually we don't see response up to 2 weeks. So with lutetium, this is our first, previously we've used samarium 153, most of our experiences with that. But with this, sometimes patients have placebo also, that after the injection they feel, pain theek hai, to ek hafte wala jo hota hai, wo usually placebo hota hai. But patients actually have reduced the dosage of their NSAIDs. So probably it is effective, but it will last for at least 3 to 6 months. Once the effect comes down, we can again treat with lutetium. We can give repeat therapy.
Good morning, everyone. First of all, congratulations to the department for starting this novel therapy, because the role of lutetium is not just restricted to bone palliation. The recent evidence suggests in cases of prostate cancer, particularly the metastatic castrate-resistant one, we have objective response rate which can last up to 1 year. And bone palliation, it's good to know that we have started the bone palliation only, but I would like if we can start this modality as a treatment modality, because this is the only thing left for these patients when everything has been exhausted. So I would like this.
So, ma'am, would you like? I just want to comment. Yeah.
Actually, this therapy is only for pain palliation. It has nothing to do with the disease progression or survival benefits. Only 2 traces in this context, radium chloride and strontium, has given some benefit of survival. So this samarium therapy or lutetium therapy, samarium has been used for last 2 decades, and it gives only the pain palliation component. And it is used when all the treatment modalities have been exhausted. As Madam has asked, radiotherapy has role in limited disease. If you have whole body metastatic disease, you cannot give whole body irradiation because there will be multiple sites of pain. So in that scenario, it can be useful. And when you're asking about the when can we start PSMA therapies with lutetium, actually, this is a low dose therapy with 50 millicurie to maximum 60 or 75 millicurie, which can be given on OPD basis. But if we have to start with PSMA therapy with lutetium, we have to give at least 200 millicuries to 150 millicuries. For this, ARB has given a guideline that we need to have a separate sort of, soak pits and drainage system, which has to be in the ward. Then only we can give, not in the ward only, also on the OPD basis, but this drainage system has to be in place, otherwise it can contaminate, because this has a longer half-life of 6 days, and when we consider the radioactivity is completely eliminated, is 10 half-life, it becomes 60 days. But most of the time, but because the biological half-life is so less, it gets excreted within 48 hours maximum activity. So considering that, 1 week at least is the period where we should be isolating them in the when patient is going back to the house or sent back to the community. So 1 week is a time period where we should be careful. So they are giving a license only once we have these facility in place. So we are trying hard to get the radioiodine therapy ward, and once our PET-CT facility will start, we'll have that one particular room, 1 or 2 rooms we can dedicate, we can start that. So we are hopeful to start lutetium therapy with after the PET-CT is getting installed also. That is one. Yes.
Ma'am, regarding my comment for objective response rate, much of the data for lutetium comes from PGI. Professor Ashwini Shud has been the pioneer on that. And in the recent CME, which the department conducted, sir has shared the data which showed an objective response rate, the tumor burden significantly decreased. They have publications.
With PSMA.
And even the therapy can be repeated after 2 years. They repeated after 2 years when the patient had recurrence with progression of the disease, and even after the second treatment, the patient showed an objective response rate. So there is data which showed that this therapy can be used to produce an objective response rate in patient in which we have no therapy left.
Not this therapy, PSMA
PSMA
based lutetium therapy.
PSMA lutetium based. I was telling about lutetium already.
Right.
Sorry to.
So lutetium basically a radionuclide, and you can tag it with different traces. Like here we are tagging it with samarium EDTMP, which gets localized in the bone wherever there is increased osteoblastic activity. Whereas the PSMA is a ligand which is overexpressed in the prostate cancer cells. So wherever there's a primary or metastatic disease, it goes and localizes there, and we can treat that. So coming to the how frequently we can repeat this pain palliation therapy, 3 months is the optimal time. If the patient has responded well, and then again he is having a pain, so after a safe period of 3 to 4 months, when you expect the hematological response and recovery, you can again treat these patients. And it has to be kept as a last resort when all centrally acting pain palliation methods and other methods have been exhausted. Because if we already have all those battery of armamentarium, there's no need to use that. Only in the cases where the bone scan is positive, and this therapy can be opted as a last resort. That is what I did.
So I think first, congratulations to the department for starting this therapy and starting to use it. What I understand out of it is that this is a radionuclide which is going distant places, and that is why it is being used in all kind of metastatic cancers, including uterine cancer, which has been shown in the slides. So I'm sure it is getting tagged. It is being tagged to other, molecules, which could be, because in cancer therapy now we have very targeted therapies which are coming up. So, what is the projection and experience of the department in using these targeted therapies, and what we should be doing in future? Some of the things which you have highlighted, that you are short of space, and even for thyroid you have problems. What I now envisage is that for cancer treatment, now we have so many therapies which are available, which are there in immunologically, all these molecules which are emerging. Plus, we have radiation oncology, we have nuclear medicine, which is very laudable. That is also come out with so many targeted therapies which are being. So I think I had asked some of you to prepare a proposal for an advanced cancer care center, in which we can have all these modalities at one place, according to ARB guidelines, because what we are finding otherwise for establishment right now is the space which is very limited in the given areas. So I think we should go for something bigger now, and actually in the state of Uttarakhand they have an advanced cancer center which they are developing in Haldwani, which has been approved for the state. But we do think that AIMS Rishikesh should have something which is exclusively to cancer. You can propose something like 250 beds for that, and all the facilities which could be there. So I think we'll set up a group which can prepare that proposal, which we can put up to the government, so that we can incorporate all these therapies and have a state-of-the-art treatment center for these.
Yes, ma'am.
That's a wonderful idea, ma'am. And every tertiary care center should have an advanced cancer treatment center. And as you're suggesting with your guidance, we'll go ahead with that. I would like to add on your comment. 50% of cancer patients with prostate cancer are totally, there's a total change in the paradigm of management. Now, this PSMA therapy has given so much benefit. Those who are having the stage 4 disease, metastatic diseases, it is totally reversing. And patients are having good quality of life for over 5 years and many more years. So this is totally, change in the paradigm, not only for CA prostate, also for neuroendocrine tumors. And with the newer targeted agents like FAPI we are getting. So many other malignancies can also be treated with these radionuclides which are labeled with the newer targeted, that is FAP inhibitors. So the scenario is totally changing. We are going to have a lot of therapies, and we wanted to do, but because of so much of whatever happened, constraint. But hopefully, we are hoping at least OPD based therapies we can start once the PET gets established. So we are dedicating 2 rooms, which on 2 days of the week we can administer therapy, and I hope the urology department will be happy to do that.